So let's go for the demonstration. So I'll be actually going between the anatomical map and between the ultrasound so that it is easy for you. I will be switching between the scenes so that you can actually see the structures and also you can understand at what area we are looking for. Am I audible clearly? I'm not sure.
Yes.
Okay, fine. So first I will be showing the most important thing is the counting of the levels. Now at which area the counting of levels is the most easier. So for those who are doing ultrasound for long, it is one of the very simple thing, but those who are new, it may be a little bit difficult. So let's start. Usually for counting of the levels, instead of going exactly, is it visible? Yes, visible. So instead of going exactly at the midline, just come a little lateral and especially over the lamina. So now we can see the horse heads. So below we can see only one line. Let me show you. Let me draw that line. So basically at this point, you see it's a single line. Here it's a single line. Okay. And after that, we are starting with, let us clear. We are starting with one by one lamina. Okay. So once we are getting, so the first gap, it is the between the L5 vertebra and this is the S1. Similarly, it is the L4 and if we move up, it will be the L3. Okay. So in that way, we can actually, by looking at the counting at the laminas, we can go up to the L1 level. Okay. So this is a very simple way by finding out the level in the lumbar spine. So now this last one was the L1. Now what is coming at the middle is the D12. Okay. So in that way, we can count the level of the vertebra. Understood everybody? How to count the level?
Yes.
Okay. Now, let us start from the lateral most side. So in a number of cases, we start demonstrating from the medial side, but I have found that if you start from the lateral side, it is comparatively easy for all to understand. So when I am in the lumbar spine area and a little bit lateral, let me increase the gain slightly. Okay. So that gain. Yes. Now hopefully you can see the gain is adequate for you. Okay. So here, this view, what we are seeing is basically a trident view. We can see three transverse processes. Our echoes are cutting in between three transverse processes. Now, if you look at in between two transverse processes, okay, then we can see few important structures. So let me stop and I am increasing the depth a little also so that one structure I can show you by increasing the depth. You can see something moving below. Can anyone appreciate? With the respiration of the volunteer, something is moving below.
Yes.
So what is this structure?
Peritoneum.
Peritoneum, perfect. Just above that structure, we have a muscle. Let me show you with a pointer. Settings. So we can see from here to here up to the moving point, there is a muscle.
Was.
This is the psoas. And just above the psoas, there is a hyperechoic structure. This one. This is the intertransverse complex, which includes the intertransverse lateralis muscle and the intertransverse ligament. More hyperechoic is the ligament, less hyperechoic is the muscle. Now, just above this area, we have another group of muscles. So, what is this muscle? This is
Erector spine.
erector spine. Perfect. So, once you have understood the anatomy, everything is like a child's play. Now, from this area, you just try to see carefully. I am moving a little lateral. So, instead of going medial towards the spine, let us go a little lateral. Okay. So at this area, we no longer see the transverse process. So transverse process ended. But here we are having two muscle layer. Above, I am showing this muscle layer. This muscle layer is the quadratus lumborum, and sorry, this muscle layer is the erectus spinae, and below it is the psoas. And at this point, the psoas is having maximum width because now quadratus have not arrived yet. And in the junction of the anterior 2/3 and posterior 1/3, we have some nervous structures within the psoas. Okay, so these are the area of the lumbar plexus. Now, as we go more lateral, okay, as we are going more lateral, then what is happening? A third layer of muscle is arising between these two. So let us show in this which area that is more maximum. So it is over the spine. Now we are going to the lateral. Now, as we are going further lateral, then a third layer of muscle appearing. So now you can see this is very thin now, the third layer. Now the third layer, here, let's look at this point. Okay, this is the third layer of muscle. So as we are going slightly more lateral, see this layer, we can see the width is increasing and the psoas is decreasing in width. So what is this third layer of muscle? Can anyone tell? Quadratus lumborum. Fine, you have understood beautifully. So here the quadratus is coming in the lateral view. So basically, when we are taking from medial to lateral, we can look at this way. If you want to do a QL block in this view also, you can come and go. For us, if it is a QL myofascial, we can come and go inside the do the QL4, or for the blocks of the anesthesia, you can come just anterior to the muscle. So it will be anterior layer of the thoracolumbar fascia. Okay, and here it will be the middle layer of the thoracolumbar fascia. Now, here I am going back to the spine transverse process and the intertransverse area at this point. Still, we are having over the psoas and the intertransverse ligament area. Now, as we are moving further medially, okay, now we are taking the probe slightly medially, and you see again psoas is reducing in size, quadratus is maintaining there, and now you see the shape of the previously the shape was like a finger-like projection like this, but as we are moving medially, the shape changes. Okay, and how the shape changes? The shape becomes a double hump structure. Okay, so all these areas let us freeze and let us show it is becoming a double hump like structure. Okay, and this is known as the camel hump view. So basically here at this point we are having one hump and below there is another hump, but as we go further medial it will be a little more clear as well. Here in this area it is there, similar to here also. Okay, so this is the camel hump view, and going slightly medial and lateral we can make it more or less prominent. So let us go and try to see how it looks when from this area we are moving slightly medial or lateral. Okay. Now, one thing I have not told, but I think it is obvious and you have already understood that the left part of the skin is basically the anterior, upper part, and the right part. My index marker is above. Okay. So now we are at the camel hump area. Now, if we hold the probe like this, that one side it is the camel hump and other side it is the finger-like projection view. Okay. Now we can see there are moving vessels at this point. And you see at this point there are some moving vessels. Try to observe and please say yes if you have able to see it. Are you able to see that?
Yes.
Okay. So these are the radicular arteries. So this area is the nerve root area. Now, if you want to go for the injection, let me freeze and let me show that if we want to go for the injection, we can come like this. So basically, here we can come like this, and then from this side to this side, see, everyone knows that slightly towards the middle side and upper side, it is mostly the radicular artery. That is why safe triangle we usually avoid. And here you can see the artery slightly towards above, okay? So close to the safe triangle. So we'll prefer going at this point that is close to the Cameron's triangle. But there's also a little bit, the problem remains also because here also we cannot see the contrast spread. So at least we can do a guided injection definitely, but only using this one sometimes can be problematic as well. Okay. Now we are going for so this is the technique mainly used for the ultrasound. Nowadays I should not call the ultrasound guided, rather ultrasound assisted root block or transforamen epidural steroid injection. Okay. Under this view, this structure is seen very beautifully. So remember, so we have to tilt the probe slightly, and in the upper part we'll be seeing the finger-like projection view. Lower part will be seeing the camel hump view, and once we are seeing in the lower part the camel hump view and upper like finger projections view, we have to find out the radicular artery, and just by the side we'll be getting the area for the Cameron's triangle approach. So this part I think everyone have understood. Now let me show you how we have put the probe in these areas. Okay, so let us go to this second screen and let us show you. So here first this layer of muscles was there. This was the quadratus lumborum. This is the iliocostalis. Okay, then we are having this longissimus. Then after hiding the longissimus, so iliocostalis, longissimus, we are not able to differentiate. But once we have hidden these two muscles, then we are getting the multifidus. Multifidus remains a little below. So we have shown you the multifidus as well. Now from this area, I am clearing this area. This is and the lateral side. These are the oblique muscles of the abdomen. Okay, I am hiding all those oblique muscles. Now, initially, I have shown you the scanning at this point. Basically, I have shown you the scanning over this point. So you can understand, we are scanning over the transverse processes. We have seen the this lateralis muscle, intertransversalis lateralis muscle. Then we have gone lateral. So posteriorly, we have in this area, what I have removed is basically the erector spinae muscles, group of muscles, and this is basically the quadratus lumborum muscle. So I have shown you by going to this side the transverse process. Then I came from this area to just above the horse head view. So here we are having this area where we are having this. These are the mammillary processes, and below at this point is usually the accessory processes are there. So we have came over the mammillo-accessory area and we have shown you the camel hump. Next, we'll be moving slightly more medial at this point. So we'll be moving at this point while we'll be over the lamina. So here we'll be moving at this point just over the lamina, and then we'll be showing you the intrathecal space from the lamina. Basically, I have started from that area only where you can see the anterior portions as well. Okay. So let me go back and let me go to the, okay. Stop sharing. Sharing and go to this. Okay. So hope you have understood. Let's go back to the previous screen. So here the basic anatomy, and you have to relate with the ultrasound images, and your learning will be complete. If you don't compare with the anatomy, it is a little bit difficult. Let's go going for the third view or the laminar view. But before that, one muscle I have not shown you, though clinically it is not that important, but especially over the in between the camel hump views, at this point you can see a muscle. Okay, so in between two camel humps, let me reduce the depth. Okay, when we are in between two camel humps, you can see another muscle. So basically, this is the Intertransversalis, medialis. So they remains close to the mammillary process. Lateralis remains here, okay, at this point. Here you can see the glistening portion of the ligament and the muscle there, okay, in between the intertransverse area. Now we have known about the camellum area. After the camellum, we'll be going slightly medially. And when we have gone slightly medially from the camellum, we can see this type of images, okay. So these are the known as the horse head views, okay. So here we can see the horse heads. Now the question is, when we are exactly paramedian sagittal view, not paramedian sagittal oblique view, we usually do not see the openings more clearly. So here we are at the laminar view in the paramedian sagittal view. Previously, I have shown you with the paramedian sagittal oblique view when we started, but now we are actually at the paramedian sagittal view. So at the paramedian sagittal view, we are seeing this portion. So these are the laminas. Okay, these are the laminas. And below in this gap will be the thecal space. But as we'll be moving the probe to the paramedian oblique, then the structures will be much clearer. Especially the anterior structures or the thecal structures will be much clearer to you. So let me defreeze it and let me show you in the paramedian sagittal oblique view. So in the paramedian sagittal oblique view, structures are much more clear here. Okay, as we are making it oblique, we can see the intrathecal space more clearly. So let us focus on a specific area of the intrathecal space, then it will be easy. So here, these are also horsehead views, but in between these horsehead areas, we can see the glistening anterior complex. So here is the anterior complex, here is the thecal space, here is the posterior complex. So remember, whether it is epidural or whether it is spinal, so if you are doing it ultrasound assisted, then you can take the needle like here. Usually we prefer hitting first here, then going inside, then you can go to the for spinal anesthesia, you can go for the intrathecal space. For epidural anesthesia, you can go for the LOR and you can come into the epidural space. So in difficult cases, but you cannot see or you cannot blindly do the procedures, you can take the assistance of the ultrasound. So you have all understood this portion. What is the importance of it? So it's good for the counting as well as it is good for these procedures as well. Okay, let me clear all the drawings and let us go for the spinal view. I have told you spinal view I have not started because spinal view is not difficult. If you have practiced, everything is easy. So after this paramedian sagittal oblique view, let us take at the center. Now once you are at the center, you see everything becoming superficial. Okay, so here at the superficial portion, we can see some bony prominences. Okay, so here we can see at least two bony prominences we can see at this point. So let us freeze and show you. So these are the bony prominences that we can see. And below we cannot see much, but these are two bony prominences that is seen beautifully. This is one, this is another. Sorry, it will be better if we take a line rather than an arrow. Okay. So here you can see one, here you can see another. Okay. So these are actually the spines. Okay. So the spines, they are shown as glistening, and below you cannot see because it is the spinous process. So below you cannot see anything. So that is the spinous process view. But in spinous process view, counting the vertebral level is comparatively difficult than the interspinous view. That's why I told you to count it under the, not the interspinous view, rather in the laminar view. Now we are going for the spinous and the interspinous views. So how to go for the spinous view and the interspinous view? This is also important because initially someone has answered me wrong. So here, can you see the anterior complex? Yes or no? So here we are seeing the anterior complex. See, it depends where you can see and where you cannot see. Though in practically while doing the procedure, we do not bother much about the anterior complexes, but for the learning, at this point, we can see the anterior complex. It is coming here. Though it is not as glistening in all patients, it will not be the same. So it is not as glistening as the other areas, but you see at this area, focus at this area, okay? Sometimes you will be able to see some complexes are there, okay, between the gap, and sometimes it will be hidden, okay? So depending on which area you are, let us increase the depth, then it will be a little bit easy for you, I think. Huh? So sometimes we'll be seeing and sometimes it will be lost. And it also depends on the plane at which you are, because if you are in a horizontal plane or if you are in a transverse plane, because it depends on the plane at which you are actually putting the needle. So here you can see a glistening top here at this point, okay? So it is definitely the spine. But as I move, the glistening part is lost. Here you can see the glistening part. As I move, the glistening part is lost. You can also increase the gain to see more. But yes, when it is coming and you can see a little structures below, it is usually the intertransverse area. And when we are exactly over the spine and we cannot see anything below, it is usually the intertransverse area. But all depends on the patient. This patient is very small, so I am not getting the anterior complex view very beautifully. It's true. But if it definitely patient to patient, it varies a little. But that is not the area of our procedure. So let us focus on the lateral part of the facet joint part. So when we focus at this point, I'm just making it away so that you can see at this point, can you see a clear facet joint, a facetal cleft? This is the intertransverse area because we cannot see the transverse process, okay? But we can see a clean facetal cleft. For injection, usually take the cleft at a comparative lateral side and then enter from the other side. So for the intraarticular injection for the facet joint, usually this is a good view. Here, let us freeze and draw. So in this picture, we can see this cleft clearly. Okay, so where is the drawing annotation? We can see this bony cleft clearly. Okay, so this is the open facet joint. So what we can do, we can just go come from the lateral side. As I have taken in one side, it will be comparatively simple. Under the in plane view, we can go here. But remember, sometimes if the depth is too much, then it becomes a problem, the needle visualization. In that case, you just keep on rotating the needle, that you can, with the tissue movement, by rotation and to and fro movement a little, we can actually see the needle going into the joint. We may not be able to exactly going inside the joint, but it will go in the same direction. Then you will be having the feeling in the hand that you are crossing the capsule and you are going into a bony cleft. Okay, so that is how we usually go for this intra-articular facet joint injection. And remember, for intra-articular facet joint injection, ultrasound is not bad, it's good, and the success rate is also quite good. Now let's move for the other area where we will be over the spine, sorry, over the transverse process. So let us hold the probe in the same manner that we are holding the probe in a transverse way, and then we are going into scanning this area. Now, while scanning, you see in some areas you can see this glistening transverse process. In other areas, you cannot see the transverse process. Go below, again the transverse process. This is a little more below, so let us move a little up. So in some areas, we will be able to see the transverse process. So here you can see the transverse process, and in some areas, the transverse process is not there. So where you can see cleanly the transverse process and where it is starting. So at this portion, okay. So here you can clearly see the transverse process, okay. And when you will be over the transverse process, usually the swath shadow becomes a little obliterated. So see, when I am moving up and down in certain areas, you see the swath shadow is becoming hidden. So what is the swath shadow? This is the swath shadow. Okay, this is the swath shadow. This is the peritoneum. This is the quadratus lumborum, and this is the erector spinae. So here at this point where we are, we can see the swath shadow clearly. So here in the intertransverse area. So this is also hyperechoic, but it is not as hyperechoic that the lower portion is getting obliterated. So basically it is the intertransverse ligament, okay, and also the muscle, okay, transversal lateralis muscle. But here when we are coming, see, everything is under the acoustic shadow. At this point, these structures are under the acoustic shadow. So this is basically the spinous process. So in that way, we have to move up and down, and we have to find out the area where we are exactly over the spinous process, transverse process. So here we are over the transverse process. So at this point, if we stop and we come, and here in the swath, you can, if this part is clear to you, na, here you can clearly appreciate the acoustic shadow below. This is the shadow. This is the shadow area. This is the shadow area below the transverse process. Okay. But previously, this area was also visible. So at this point, if you have to block, you have to come from this side and go in the medial most part of the transverse process. Okay. So this is the area where you have to go. And definitely, if you have a stimulator or if you are using a radio frequency needle and where you are doing the sensory and motor stimulation both, then your best area in the spine for the medial branch block. And for the medial branch block, you have to do at two levels, one below and one down. And in this picture, let me draw the other structures. Hope you have already understood, but still I am drawing a little. So this muscle is basically the psoas. Portion of the psoas is below this. This is the psoas major. This is the quadratus lumborum. And this muscle is the erectus spinae. Okay. So this whole muscle is basically the erectus spinae. So we understood this part. Everyone, yes or no?
Yes.
Okay, fine. Then only a small portion is left showing you from the lateral view, because from the lateral view, in very leniency patients, it is possible to do some other procedures as well. Let me go to that scene so that we can understand the lateral view as well. So from the lateral view, when we go, let us go to the lateral view and let us hide this, okay? Hide the structures. So in the lateral view, we can see this muscle, this is the quadratus, then we can see this psoas. So basically, all the structures we'll be seeing through these muscles, okay? These are the quadratus, psoas, and psoas minor. So let us hide those muscles so that we can clear. So minor is not required. So here at this point, we can see the vertebral body. So if we put the probe in such a way that we are putting the probe like this, okay, we are putting the probe like this. Let us draw a little arrow. We are putting the probe like this. We are putting the probe at the more like this, okay, in this direction. When we are putting the probe, then we'll be cutting the transverse process, all three muscles, the erectus, spinae, quadratus, and also we'll be able to see the lateral portion of the vertebral body. So for the lumbar sympathetic block, it is important to go to the anterolateral corner of the lumbar vertebra, and that is only possible if we can see from a lateral view. So let's take the patient in a lateral view. First clear these things, and then we have to be back. We're going to the other image. Okay, so let us go and let us check. So please be a good ratio, lateral ratio. Huh? So now can you see? Yes, it is visible. Here we are actually seeing from the lateral side, and now I am keeping the index marker towards the anterior side of the patient. So in the left part of the screen, we will be seeing the anterior structures. Okay. Now at this point, we will be able to see the, now we can see the vertebral body, but we cannot see the transverse process. So I have to move up and down to come to the transverse process area. Okay. So now at this point, we are having the transverse process. So we are in the transverse process area. Similarly, here we can come and check. We are increasing the little depth because the depth we require a little more. So you are following basically the From lateral side, we are following the vertebral body. There are a lot of gas shadows, so it is a little bit difficult to see the anterior portions because of the gas shadow. Now, you can see this picture is looking like a ear of a rabbit. Okay, can you see this structure? I'm not showing by stopping it because we will not be then seeing the other structures. Here we can see the aorta. Can you appreciate the aorta at this point? Yes or no? No one is saying anything. Can
Yes,
you
sir. Yes.
appreciate the aorta? Yes. So that is the aorta. Here, this is the transverse process. Okay. So this is the transverse process. Okay. And anteriorly, we are having the psoas. If we come down, it will be more rounded and more clearly visible, the psoas. Here also we can see the transverse process. This is the psoas muscle. Laterally, we are having the portion of the, here we cannot see the all portion, but portion of the this muscle, that means the quadratus lumborum, and posteriorly we are having the posteriorly at this part, we are having this part is the quadratus lumborum. So we can see here we are having the quadratus muscle. So in that way, we can find out the structures and muscles clearly. Okay.